Hello, my presentation today is on the development and validation of a warfarin dose prediction model for patients in sub-Saharan Africa, and it's part of the Warpath project funded by the NIHR. Although warfarin is a very effective and widely used anticoagulant, it's often very difficult to predict the appropriate dose to give an individual to achieve therapeutic anticoagulation. And this is because warfarin has a narrow therapeutic index, meaning that the dose that causes under anticoagulation is very close to the dose that causes over anticoagulation. And also there is very large inter-individual variability in dose requirements, with some patients requiring less than half a milligram a day, with others requiring more than 10 milligrams a day. And getting the dose incorrect can lead to severe adverse events, for example, severe bleeding. And over the years, many dosing algorithms have been proposed, developed using regression-based or machine learning methods as well as other methods. And these algorithms typically include clinical and/or genetic variables to help predict the correct dose to give an individual. However, the majority of these algorithms have been developed in Caucasian populations, and there's a real lack of algorithms available for populations from sub-Saharan Africa. And as part of Warpath, we conducted an audit of anticoagulation control in patients from sub-Saharan Africa populations and found that control was generally low, emphasising the need to improve dose prediction in these populations. So to address this real need for a warfarin dose prediction model to be applied in populations from sub-Saharan Africa, we went about developing a dose prediction model, and we adhered to the tripod statement in terms of methods and reporting of our methods. And in order to develop the model, we recruited 364 patients from outpatient clinics and hospitals in South Africa and Uganda, and all of these patients had achieved a stable warfarin dose. And we explored 7 potential predictors, and these were chosen based on the literature and clinical expertise. And in order to develop our model, we explored 4 different regression approaches: ordinary least squares regression, quantile regression, weighted quantile regression, and nonlinear least squares regression. And for each of these approaches, we fitted all possible combinations of predictors, with the optimal models chosen with reference to either mean absolute error, mean absolute percentage error, or logarithmic ratio predicted to actual dose, depending on the modelling approach. We also used bootstrap validation to correct for overfitting. And we also had an external validation cohort, which consisted of Black or African American patients from the International Warfarin Pharmacogenetic Consortium. We also compared the performance of our chosen model to current practice, which in the locations from which our patients were recruited is a fixed dose of 35 milligrams of warfarin per week. And we also compared our model to other proposed algorithms from the literature. And in doing this, we used performance measures as follows: so percentage patients with ideal dose to reflect clinical relevance of the models, and this was defined as patients where their predicted dose was within 20% of their actual dose. We also used R-squared for fit accuracy, and also in order to assess the clinical safety of the models, we looked at percentage of patients at risk of over or underdosing, that is whereby their actual dose was at least 40% over or under the predicted dose. We found our best performing model was the one developed using the nonlinear least squares regression approach, and it included 4 predictors, which were age, weight, target INR range, and HIV status. And we call this the Warpath model. And we found that it had lower mean absolute error compared to fixed dosing and other published algorithms, although those improvements were not statistically significant. However, when we look at clinical relevance, we find that in the development cohort, when we apply the Warpath model, we have a reduction of patients at high risk of over and under anticoagulation when we use the Warpath model. And this leads to an increase in the number of patients at low risk of suboptimal anticoagulation when we use the Warpath model. In the external validation cohort, although there was a slight increase in the number of patients at high risk of over anticoagulation using the Warpath model, we found a reduction in patients at high risk of under anticoagulation, and overall an increase in the number of patients at low risk of suboptimal anticoagulation. And we have ongoing work within Warpath looking at the implementation of this model in anticoagulation clinics in sub-Saharan Africa. Thank you.